And I want to welcome my colleague and partner in this endeavor, Arlene Daly.
Thank you, Dr. Liz. Thank you, University. It's been a great evening, great conversation. This is our third annual Your Health Lecture Series here in Detroit. And I have the pleasure of introducing a wonderful social bioethicist, and she's here to present on consulting with hospital ethics committees. And without further ado, we have Dr. Jennifer McCurdy. Thank you. Thank you all. Here, is this help? Does this do anything? Is it doing anything?
I think it's just for the Zoom.
Oh, okay. Okay. I'm gonna put it on, so I don't have to hold it the whole time. Thank you so much for having me here. And there was a few people that came in. I'm gonna find out who you are in just a minute. But I've been at MSU in East Lansing for 4 years now. I'm actually, I was in Denver, Colorado and Boulder, Colorado for about 20 years before that, and Texas before that. So, in Alaska for 3 years. So I've kind of been around, but I've been in Michigan now for 4 years. And I've also had about that many different careers. And in fact, they're not different careers. It's just been sort of an extension and a growth of my original career. But a little bit of background. I was a nurse for 17 years. I was an emergency room nurse. For a few years, I worked in an intensive care unit where we recovered kidney and liver transplant patients. And then I worked in a pediatric intensive care unit for 10 years. And while I was practicing nursing, I went back and got a master's degree in bioethics because there were so many things that I was seeing in the clinical space that were they were so hard to understand and wrap your head around. There were no answers to them. There was so much conflict. You know, it's nice when you can take care of your patients and everything works out and they go home and they're healthy and it works. But so often, so many things get muddled up in the care of a patient, whether it's like social issues or there's conflict between family and patient, between the patient and the physician, between physicians and nurses, or physicians and physicians. Like there's so many things that can happen in the course of caring for a patient where things don't necessarily go right. And so I was really interested in bioethics because I wanted to know more. I wanted to be able to solve some of these problems that I was seeing on a regular basis in my practice. And then I decided, I actually taught at a Jesuit university in Denver called Regis University, if any of you have heard of it, and decided to go back and get my PhD. And so I got my PhD in religious studies, but I actually studied religion and colonialism, which is a whole nother story. But I did my dissertation on bioethics and colonialism. So it all kind of still, you know, here I am teaching in medical school. I used to teach nursing students, dental students, and PT students at Regis. So I've kind of done a little bit of everything, just to say that you don't have to always do the same thing your entire life. You can always, you know, switch things up. You can grow. You can be creative about your career. And also, I will say that I learned ethics from a lot of physicians. I shadowed and was mentored by a lot of physician ethicists as well. So, but ethicists come in all shapes and sizes. People, lawyers, social workers, nurses, physicians, trying to think of chaplains. People that practice ethics come from all different professions. So I just wanted to put that out there since we were talking about career advancement and things like that. There was a couple of people that came in later, and this whole back row and you, I want to just find out like what are you going into, or what are your thoughts? Are you going into a health related field? What are you studying?
But honestly, it's amazing that we're talking about this because when I took ethics here, I actually fell in love. There's a lot of layers to ethics, and it's not black and white. Like there's a lot of gray area. So basically, yeah. So I'm on the pre-med track.
Pre-med. Okay, awesome. Thanks.
And you read
I'm Eva. Right now, bio, pre-med, but I'm also like, I'm kind of between med school and the PED route.
Okay.
I'm Miriam, I already graduated too, and I'm currently like getting ready for the next cycle. I'm working as a medical assistant, and like Nor said, when I took ethics here, I really loved it, and also when I started actually interacting with my patients, there was like so much like more to patients than just like the skills you need to be a doctor, so I think, yeah.
Yeah.
Oh, I'm also Miriam. I'm a biology major, on the pre-med track.
Okay. You all taken ethics courses already, so I'm like, you already know this. You already know all this. Did you come in later too? Yeah.
Alpha, I'm currently applying. Most of my clinical work has been in a clinic, not really in the hospital. So I've never really been able to work on the ethical side of it. So I just want to get to know get around that for the future.
Me too. I'd like to know how to get around it too. It is so hard. It is so hard. I just so you know, I have some friends who are PAs. I have friends who are nurse practitioners. I have friends who are physicians, and they all love their jobs. And there's just pros and cons about the different paths, but I'm happy to talk to y'all later about any of that if you want. So it sounds like some of you have ethics knowledge already. How many of you have been in an ethics consult or ever, seen an ethical dilemma in a clinical setting? Can you say what it was?
There. And something was happening with like the mom, kind of like withholding from the dad, something was happening like there.
The
And
dad was the patient?
yes.
Okay, so there was a couple. The daughter brought the father into the hospital, but there was some question about whether the wife of the man that was the patient was being maybe neglected, not getting fed.
Yeah, and then like taking care of our elderly, like very like that's one of our most. And so the daughter was
So there was a misunderstanding by the, I'm just going to say this again so that for the microphone, but there was a misunderstanding that the physician thought she was neglecting her husband, but it was in fact something that was more cultural and was misunderstood. And so there was some conflict there. Okay, good. Yeah, that's a really interesting one. And I'll give you some more examples. I'm going to give you some more examples too. But oh wait, really quick, this is kind of tiny, but these were just some of our goals for today. We were going to describe the history of ethics committees, like where did they even come from? Why do we have ethics? What is the role of an ethics committee? What are some situations where you would consult ethics? So what is it like? What kinds of things do ethics committees do? And what's the difference between an ethics consultation and other services like palliative care, legal, case management, speech pathology, psychiatry? So there's all these different consult teams. And if you end up at MSU in medical school, or if you maybe some other, I don't know if other places do this or not, but you'll probably get to do rotations with some of these groups to see what they do so that you know when to consult them. But we'll talk a little bit about that too. I'm going to give you a little quiz. Okay, so basically this is what ethics helps with. The question that comes to us when we're practicing might be that this case is really bothering me and I cannot stop worrying about it. What is the right thing to do in this case? What is the right thing to do? And this is when you know something is, something's really bothering you and you can't seem to figure out what the right thing is to do, and it seems like there's a lot of conflict, that is sort of your cue that this could be something for the ethics committee. But so imagine, you say to yourself, but ethics, okay, I grew up, my parents taught me, well, I know what morality is. I'm a good person. It seems like ethics is common sense, right? It just means you're a good person. I have good intentions. But the thing is, these things are not enough to guarantee the best ethical decisions are made. So let me ask you this. What is morality and what is ethics? Are they the same? Are they different? Does anybody want to take a shot at that? Yeah.
Morality is more of a personal compass. And ethics.
Ding, ding, ding. Yes. So, yeah. So we all have a personal morality, or maybe our family has a sort of a shared morality, or our small community has a shared morality. But then when you work in healthcare, where you live in a society where our values can be very different from community to community, we have a lot of diversity. What do you do then? Because your values may not fit with their values. And so when we talk about ethics, we're talking about how do we make decisions when we're in a situation where there are multiple different stakeholders or players and our values don't all match. How do we do that? Because we can't just say, well, I'm the physician assistant and my values are this, and therefore you need to do this. This is the decision you need to make. And so that's why we can't just make decisions based on our own personal values. We have to make decisions in a way that takes everybody's values into account, and may even weigh the patient's values more strongly, because the patient's the one who's going to have to live with these decisions. So good. That is really good. Now, what is the difference between ethics and the law? As long as I'm just following the law, am I doing what's ethical? Is that it? Is it?
Yes and no at the same time, because sometimes the law is not ethical. An example of that can be abortion laws currently. Also, ethics can have different perspectives, so someone might be unethical.
Yep. Yes. So not all slavery, right? Laws can be bad. They can be unethical. Most of the time they're not. Most of the time they're expressions of sort of shared morality within our society. But as you know, people are very divided on the abortion issue. And so some people might think that it's unethical, even though it's lawful. Or once it's not legal anymore, some people might say it should be legal because it's unethical to not provide. So you can see where the values clash, right? Like that is a true ethical dilemma. You have people that truly believe two completely different things. And so the law really, okay, here's the next question. Does the law or ethics, which one trumps the other? Law or ethics, which one's higher?
Law.
Okay, anybody else want to? Why? You say law comes before ethics. Why would that be?
If it is law, it is generally accepted to be the ethics.
What if you were against abortion and then you were asked to give an abortion?
Well, your own feelings should not dictate.
Okay. Yeah. Yeah, so you have to know the law so that you can follow the law as a physician, right? You want to be lawful. And most of the time you will follow the law, right? Like that's in your best interest. But there may be times when you there may be times when you disagree. Like, let's use abortion again as an example, because that's so polarized. And I mean, even like if you go to, I think it's Kansas City, you can go to what is it? Kansas City, Kansas. On the other side is Kansas City, Missouri. And literally physicians that are primary care physicians or OBGYNs have to practice differently, even if they practice on both sides of Kansas City. This state, they can provide abortions, and this state, they can't. And so, I mean, like, I mean, that's just such a crazy thing. But in one place it's legal, in another place it's not legal. But if you have the ethics, so ethics can trump the law, or it can extend the law to even like greater depth and nuance. When you have, like you were saying, when you have a situation that the law doesn't speak to, it's like, do not kill. But what do we do in this case? And is giving someone a little more morphine at the end of life, is that killing? Or is that just ethical? Is it just providing relief from suffering? And so you can see that like the law maybe sometimes isn't really clear about things. And sometimes you might have to do things that could potentially be illegal or could potentially maybe take you to court. That's not where we want to go with this. But you can see that there is this sort of play between the ethics and the law that is a little bit muddy. Because the law doesn't tell you everything you can and can't do. You get into these situations in medicine where it's like, I don't know, like there's no law that says what to do in this case. So that's why there's ethics committees, because you don't want every case in the hospital or in your practice to go to a judge. That judge knows way less than you know as a physician or as a PA or as a nurse practitioner. Way less, and way less than that family knows what's best for them. So for all of these kinds of things to go to a judge to decide whether it's lawful or not, I mean, sometimes it comes to that, but we really should be doing that together with our patients to address the nuance in it. Okay, so this is just sort of the formal definition of bioethics. It's a systematic study of moral dimensions, vision, decisions, conduct, and policies of life sciences and healthcare, which employs a variety of ethical methodologies in an interdisciplinary setting. That's a mouthful. Basically, that says it's using systematic ways to look at the ethical dilemmas of all of these different moralities. So it's systematic. I think that's the key word, is when we do an ethical analysis, we're not just saying, well, you feel this and I feel this. And so then like, what are we going to do? We'll flip a coin. It's let's look at everything. Let's get all of the information. Let's put everything out on the table. Let's get all the stakeholders here. Let's decide what's best for this person in this situation, in this context, based on their religion, based on their culture, based on their values, based on what's legal. So it's really just this sort of systematic way of looking at these issues, rather than just sort of throwing a dart. Okay. So here's some examples. I'm going to give you some examples. So an ethical dilemma, it's about values. It's 100% about values. It's not about legal necessarily, although we still have to follow the law and we have to know the law. We have to know that abortion is legal or illegal in our state in order to know how to practice, Okay, think about this. A pregnant patient with a life-threatening cancer refuses treatment that could save her life but harm the fetus. So let's say you have a mother who's 5 months pregnant, and they say they just get diagnosed with stage 4 cancer. And I actually just recently saw this very scenario. And that mother says, or that expectant mother says, I am not going to get the treatment I need for this stage 4 cancer because I don't want to kill my fetus, my, soon to be, only a few more months child. So what values conflict is there? Like if let's say you're the care provider for this patient, where's the values conflict there? What is the first gut feeling you get? Yeah.
Like,
So you want to do what's best for the patient, but the patient wants to do what's best for the fetus. So what's the values conflict? Yeah. So it's the mother's ability to make an autonomous decision. She's an adult. She can make her own decisions, or they can make their own decision. But there's a sort of a disagreement. Like the physician might be like, oh, my gut tells me, my morality tells me I cannot let you die. You are a breathing human being right here in front of me. I cannot let you die. And it's kind of against the idea of the physician's whole meaning of life, in their career is to save lives. But you do have two lives, but this is the mother that you can sit here and talk to. So that there is a values conflict there. There's the mother doesn't want her baby to die and wants to make an autonomous choice to sacrifice herself, her own treatment, and potentially die from it. While the physician might say, no, I think the beneficence is the word. For those of you who are taking ethics classes, the benefit really is that we need to save this mother's life. And so what do you do? And it says that is a true ethical dilemma. What do you do here? I'm not going to tell you that yet, but oh yeah. Yeah. Yeah.
Wouldn't you look for another way to see how long you can delay treatment?
She did end up delivering the baby and then she got treatment. Yeah. So yes, you would still, that would be part of the whole analysis is you want to go much deeper and say, okay, what kind of treatments are available? How long do we have? What are her symptoms? What stage is she? How soon can we start the treatment? Will it harm the fetus? At what stage in the fetus's life can you start the treatment? Those, can we induce early? When will the baby be okay to maybe be premature? So there's a lot of things that would go into that. Okay, so another values conflict. Let's see this. During the pandemic, there are limited ventilators available. Doctors must choose who gets a ventilator and who doesn't because there's not enough and there's too many people that are having trouble breathing. What's the values conflict there?
Basically,
Again, it's kind of the same thing, isn't it? It's two different people. You've got these patients who all want to live. They all probably want that ventilator. And then you've got not enough ventilators. So there's got to be some choices made between these patients. Do you go with the person who's the sickest, who needs it the most? Do you go with the person who's the youngest? Do you go with the person who has the most money? That's could be something. So how do doctors make these decisions? Well, often what happened during COVID was ethics committees got together and they started really thinking through what's the most fair way to do this if this comes down to, if this is what happens in our hospital, that we actually have to make a choice. And so ethics committees they literally had all these people from all over the nation, different ethics committees had all these models about, what's the most fair? Should it be random? Should it be like based on certain traits? And then there's even some more thinking through, like, can we share resources between hospitals? And that did happen in a lot of places, like hospitals would pull together. But the problem was hospitals were also, they didn't want to give up patients because that's their bottom line. And so there's competition between hospitals, but then at this time, there was also some effort to collaborate based on some of these limited resources. So ethics committees actually helped to devise some of these and then continue to review them even afterwards and update them. And this could happen again, right? Okay, a terminally ill patient in unbearable pain requests medically assisted death. What is the values conflict there between the care provider and the patient? Yeah. So, yeah, that's exactly right. So you may have physicians that would be that live in a state, that practice in a state where this is legal, where medical aid in dying is legal. And even so, for some physicians in that state may say, I can't participate in this because to me, this is killing and I can't kill. Another physician might say, I think this is just people's choice and it's relieving suffering. And we've tried everything else and there's no way to relieve this person's suffering and this is their choice. And so again, you see like very different values and you get all of these same kind of people in the same room. And what do you do? And then you've got this patient who actually has unbearable pain and they've tried everything and they just are done. They're tired and that is the only way that they can see that to end their suffering. And so we can talk a little bit. We could talk all day about this one topic, right? But were you going to say something? Okay, I'm going to try to repeat that. So when you have a patient that they're in pain and they're requesting medical aid in dying, how do you make sure, first of all, that this isn't like depression or some sort of psychiatric issue, or is that your question?
Or just someone the pain.
Oh, that maybe there's something else could be done for the pain rather than before you actually think about medical aid dying.
It's just coming from.
Okay, so you're saying if it's just coming from, I'm just in so much pain, I want to die, not their actual wishes. So a lot of people that end up doing this, that decide to do medical aid in dying, they're people who have endured this pain for a while and they've gotten all the treatments that they possibly can get. And some of it, I know Canada was doing a little run. They've stopped this since then, but they were even saying that psychological pain that was untreatable, people with deep psychological untreatable pain could actually do medical aid in dying. I think they're not doing that right now, but there was even some talk about psychological pain. But if you're in physical pain, obviously you're going to try to do everything you can to relieve that pain first. And you're going to go through palliative care and all of the different things, hospice care, palliative care, the things that you can do to relieve it. And it really comes down to the patient's, what the patient says they're experiencing. And we just have to believe that if their pain really is not endurable, we have to believe that. And of course, we're going to try to do everything we can to relieve it first.
I'm sorry for all the follow-up with like a power of attorney prior to it.
If a patient has a power of attorney
and they want a medical assistant death, but the power of attorney.
Okay, so if a patient has a power of attorney, meaning they can't make their own decisions for themselves, then they can't do medical aid in dying. If they do not have decision-making capacity, they can't participate because they have to take the medication themselves willingly, knowing what they're doing. Yeah, it's a good question. Okay, last one. A teenager requests contraception without informing their parents. What's the conflict in values there? Yeah.
They're underage.
Okay, so you've got a teenager who wants to do this maybe without their parents knowing, and their parents may not approve, but then you kind of got this gray area, right? Where teenagers can make some decisions for themselves based on the state that you live. Are you seeing this trend? But bioethics is very state dependent. So you've got to know wherever you end up practicing, you've got to know your own state policies. And so in some states, you can have these mature minor clauses where people who are, I don't know, over the age of 13, let's say, it depends on the state, can make decisions about getting birth control or getting treatment for STDs or even pregnancy treatment without their parents' permission. In other states, you can't do that without your parents' permission. But there is this sort of gray area for teenagers that we want them to get the treatment that they need. And if the barrier to getting important treatment like STD treatment or the kind of birth control that they want, if the disease is worse than the reporting to their parents, we want them to seek the treatment and to trust the medical system. So there's this whole gray area there about like, is a teenager autonomous about certain things? When do their parents need to know? How do we protect the teenager? There's a lot of different values there. And you can imagine people are going to disagree on this. So those are some examples. I'm going to just check the time. I might skip some of these because I wanted to really go through that. Okay, how did ethics start? And I just want to give you just a few cases here, a little more storytelling. So ethics, the field of ethics has only been around since like late 1960s, early 1970s. So it's not that old of a field. And it really didn't start. So before 1960s, people just died and we couldn't do anything about it. You know, we could give people antibiotics if we felt like that was, but if they went into respiratory failure, there was no ventilators to put them on. We didn't keep people alive. We couldn't keep people alive. We didn't have the technology. And so a lot of medicine was, you know, it was maybe treating infections and things like that and treating pain, but there wasn't any really life-saving technologies. So really only in the 1960s, we start to see some of this technology that's just completely changed the face of medicine. And it's created situations where we have to make decisions where before we didn't have to make these decisions. If someone was going to die, we just help them die well. Now it's like, well, should we put them on a ventilator? Should we put them on dialysis? Are they going to have a good quality of life? Do they want that? Do we think they need that? You know, and there's all of these questions about like, when do we take them off life support if they can't make decisions for themselves? So all of a sudden we have to make these sort of godlike decisions for people. And I say we as a society, as physicians, as patients and family members having to make these decisions that we've never had to make before. It creates a lot of distress. One of the first times that this came up was in 1962, the dialysis machine started to roll out and actually be used on patients, but there weren't very many of them. There were very few of them. And you've all these people in kidney failure. And so you had to decide who gets the dialysis machine. And so they actually literally, this was in Seattle, this hospital came up with a committee, and I kid you not, it was like all of these lay people, and they said, we're going to get a housewife, even the word housewife, but that's how they listed a housewife, a lawyer, and a businessman, a chaplain. I don't know. Like they came up with this whole group of people. They just picked like a random smattering of people. And they said, you are going to make decisions about, because we want this to be a decision made by society in general about who gets the dialysis machine. And then they gave these people information about the patients, like, they have 3 kids, they're 38 years old, or they're 95 years old, or they have a prison record, or they have, you know, like they just literally all of these social categories. They just basically said, which person deserves to get dialysis? Which person deserves to get these life-sustaining treatments? What is wrong? What was wrong with that? I mean, this was their first time anybody had to try to do this, but what's wrong with that? Yeah.
Well,
Yeah. 100% biased. So it's based on people's idea of who's a good person or who deserves it. But this happened, but this was early on. And, this was also we were very unsophisticated in this way. And then you had these cases in 1970s that there were several of these cases, but Karen Ann Quinlan and Nancy Cruzan were two of them. And they're different cases, but they also are very similar in some ways. Do you know these cases? Do you remember these from your ethics class?
Unfortunately, no. I
Didn't go over these. So these were, okay, so Karen Ann Quinlan was a college student, and I think she was taking some kind of diet drugs, diet medications, and then she also was drinking, and she'd been mixing a bunch of stuff. And I think she was found in her dorm room, and she was unresponsive and she wasn't breathing. And so, of course, they took her to the hospital. They tried to resuscitate her. But by the time they were able to get her to the hospital, she didn't have enough oxygen to her brain for long enough that she was in a persistent vegetative state. And so this was early ventilator times when we just started having ventilators and putting people on ventilators to save them. And they said, well, okay, they had her on a ventilator. They were feeding her through a feeding tube, and they're like, maybe she'll get better. And so they kept her on for a long time, and she wasn't getting better. She wasn't interactive at all. She was basically just laying in a bed, and she was being fed, and she had a breathing tube in. But her parents said, and this was after a long time, her parents said, you know what, she's not going to ever get better. We just want to take her off the ventilator. And of course, this was early ventilator times, and they were like, oh no, we can't do that. That's murder. We cannot. If we take her off the ventilator, we are killing her. We can't do that. And her parents said, well, we really don't think this is how she would have wanted to live. And they were like, well, so the parents sued. They took the physicians to court. They took the hospital to court. And back and forth. But needless to say, what ended up happening was they did finally decide that they could remove the breathing tube and take her off the ventilator. But guess what? She continued to breathe on her own. So she actually didn't need the ventilator. So now she's just being kept alive by the feeding tube. She didn't wake up. She didn't have it. Her neurologic status wasn't any more improved, but she breathed on her own, which people in persistent vegetative states can. They can breathe on their own. Sometimes they can even have sleep-wake cycles where they can look like they're awake sometimes and they're asleep other times, but they're not really interactive. They're not registering when you talk to them, or they don't seem to be being able to be. So that was that case, but they were like, we're not taking the beat out. That's okay. But then comes along Nancy Cruzan, also a very young adult woman, was in a car accident, was ejected and landed face first in a puddle and stopped breathing. Same thing, ended up in a persistent vegetative state. She was not on a ventilator. She was just being fed through a feeding tube. This was the case where the parents said, we want to stop feeding her. And again, it was like, no, we can't do that. That's murder. Feeding is so elemental. It's so nurturing. We cannot stop feeding someone. Like, we can take them off the ventilator, but we're not going to stop feeding them. And around again. And the U.S. Supreme Court, it ended up going to the U.S. Supreme Court, and they said that if you're going to take her off of if you're going to stop feeding her, you need to have clear and convincing evidence. Have you heard that? We need clear and convincing evidence that she would not have wanted to live this way. So then they went back and they went to all their friends and they got all these people to say, to testify and say she would not have wanted this. She told me one time if she ever, was in a vegetative state, she wouldn't want to live this way. And so they were able to get enough information from people that had talked to her that said that she wouldn't have wanted that. And they did end up taking her. Finally, after a long battle, letting her go. and not feeding her through the feeding tube anymore. So those are just some of the early cases where we're just trying to figure all this stuff out. We still struggle with taking people off ventilators. We still struggle with deciding, like the God committees with the dialysis machine. COVID showed us that we're not done talking about what do we do when we have limited resources. These things keep coming up over and over and over again. So these are the things ethics committees deal with. Any questions so far? Do you have any examples of this that you've heard of, like other ethical issues like this that you've heard of that have come up in your studies? Okay, do you want me to give you a quiz? Really quick, these are the 3 things ethics committees do. We do case consultation. So sometimes, like, let me give you an example. So this happened when I lived in Boulder, Colorado, but we had a patient who had a, they were using IV drugs and living on the streets, the patient was, and ended up with endocarditis and had bacterial vegetation on their valve, one of their valves in their heart, and needed a valve replacement. And so the cardiac surgeon did the valve replacement and said, you know, you really need to stop doing IV drugs. It's going to kill you, but we're going to do this. And the patient went back out, started using drugs again, and a year later was back in the same hospital needing another valve replacement. And I was called as the ethics consultant because the surgeon's like, I'm not doing it. I'm not doing it. Like that was their one shot. And so this was a question, like, how many shots do people get? You know, do people have to be clean for a certain amount of time before they can get this surgery? Those sorts of things. You see that with organ transplantation. Does somebody have to stop drinking for 6 months before they can get the liver transplant, or those sorts of things? These kinds of things we also deal with. And I will tell you, they're different at every hospital. So there's no rules, but what we do is we have a lot of ethics literature where we can say, here's what this hospital does. Here's what these surgeons do. Here's some of the ways people have looked at these situations. And so it was so bad because here I was trying to fight for this guy and say, we need to do this again. It's the right thing to do. We just need to do it again, give him another chance. And his friends are coming in and bringing him needles while he's in the hospital, and they're finding him in his bed. And so it's like, oh, don't do this. Like, you want to help people so badly. And these are such hard problems. So case consultation, that's an example of a case that I had. And there's many different kinds, but policy review, we write policies. Ethics consultants write policies. If you worked in a hospital, you could also be part of an ethics committee. So I do ethics consultation at McLaren and have a lot of residents that sit on the committee. And there's a couple of attendings as well. They kind of come and go because they have a lot of other things they have to be doing, but the residents are there every month. And so we do a lot of policy review, like DNR, like the DNR policy. When can somebody be a DNR? When can they rescind their DNR? End of life kinds of things, advanced directives, all those kinds of policies. We also do education. So we actually, with nurses, when I was at Children's Hospital in Colorado, I had something like 18 departments, and I had a nurse from every department, and we had a subcommittee, a nursing subcommittee of the ethics committee, and we looked at ethical issues that nurses and the physicians that they work with experienced together. And so we did a lot more like interdisciplinary education. That was really fun. Okay. I'm going to just skip to this because I want to give you a little time to ask questions. So these are some of the services that overlap with ethics. What does psychiatry do? in a hospital, let's say, what does psychiatry do in a hospital? Do you know? Yeah. Yeah, so if people have mental illness, if there's some question of whether they have capacity to make decisions, they can come in and interview them and assess them and things like that. So a lot of times people will call ethics committees to do assessments on whether somebody can make decisions. We also will call the psychiatrists in to do more in-depth assessments, especially if it's a really big case, like somebody's going to die and they have to make a decision about a surgery or something big like that. I'm going to skip speech therapy. Well, speech therapy is really actually an important thing. We had a guy, this was also in Boulder, that had a previous head injury, but he was needing to make some decisions about some treatment, and he would just grunt. So he already had a deficit, but we couldn't tell if he knew what we were saying or if he didn't know what we were saying because he was just grunting. But speech therapy said, you should have called us because we could help figure out if his yes was consistent or if his no was consistent. We could help figure out, like, if he's understanding what you're asking him and if he's consistent. And if he has a consistent yes or no, then we could ask him questions like, do you want this or do you not want this? And so we hadn't even thought about asking speech therapy. We're just like, well, he clearly can't communicate, but they can help with communication issues. Palliative care hospice, especially with people who are chronically ill, maybe have cancer, have a lot of symptoms, or end of life for hospice. Case management, usually they're social workers and they do discharge planning and things like that. And legal services, there's always legal services in hospitals. Okay, so here's my question. A patient is medically ready for discharge, but has no safe housing, no insurance, and needs home oxygen. Would you call an ethics consultant for that, or who else would you call? I'll go back. Yeah. Case management, yeah. Maybe palliative care if they're having trouble breathing and they need some relief. But yeah, it'll be case management because they're going to help the patient get ready for discharge. But oftentimes they'll call us and they'll say, we don't know where this patient's going to go, and we're just going to have to send them to the street because they don't have a home. And that ends up being an ethical issue, right? Like, they can be discharged, they're ready, but there's nowhere to send them. So sometimes we'll get called on those, even when it's more of a case management issue. Okay, next question. A patient with metastatic cancer is experiencing severe pain and emotional distress. The family is struggling with the prognosis and the care goals. Who would be called for that? Yep, so palliative care helps to figure out what are the patient's goals, what do they want, and some end of life discussion. They really need to know how palliative care will help with the pain and emotional distress, but also hospice can help with what are the goals of care here? What are we trying to achieve? A patient in the ICU is unconscious and has no advance directive. The family is divided. Some of the family want aggressive treatment and others want comfort care. The medical team is unsure how to proceed. So the patient has no advance directive. But the family, it sounds like the family is going to be the decision maker, but they don't really know what the patient would have wanted. Some are saying that they would have wanted to keep. So this could be legal. But I think what this would do is first it would go to ethics, because that's what you're going to say. It's an ethical dilemma. And well, what is the legal person going to say? They're going to just say, well, yes, there's no advance directive and we need one. And the law is if you need an advance directive to make these decisions. But oftentimes we have laws that say the family can make the decision for the patient. Every state is different again. And right now there's a law coming through Michigan that's a surrogate decision-making law, and it hasn't, I think it's still going through. It's gotten stuck in a few places, but it says if the person can't make the patient can't make decisions, the first person that would make it is their spouse. The second person, if there's no spouse, is their adult child. The third person would be their parent, and kind of like to all the way down the line. Michigan doesn't have that right now. Right now, it just says a surrogate, whoever that might be, and it's really cloudy. And so Michigan's working on that. But there are laws about advance directives and who makes decisions for people when they can't. Know your law. But here we'd say, we got to get the family together. This is something ethics would do. Let's get everybody together, everybody who cares about this patient, and let's talk about what would the patient have wanted, not what do you want because you don't want to lose them, not what you want because, for whatever reason, what would your loved one have wanted in this case? And so that's something that ethics would do. A patient wants to revoke a previously signed DNR, do not resuscitate, but the family insists it must remain. There's confusion about who has legal authority. The key word is legal. Legal. So if you actually have someone who's contesting a legal document, of course, you've got to bring in the legal folks. Yep. 100%. 100%. We have to work together on these. A patient is admitted for chest pain and begins expressing paranoid delusions and refuses all medications, thinking that staff are trying to poison them. What'd you call? Psych. Okay. See how this works? Okay, last one. A terminally ill patient demands aggressive chemotherapy that the oncologist believes will cause harm with no benefit. Ethics. Why? So you want, yes. So you don't want to harm, the oncologist doesn't want to harm the patient, but the patient wants to make their own decisions. They want to just go for it. And we see that a lot. Patients are like, just go for it. I don't care if there's 1% chance that this is going to help. Okay, so I'm going to just go there. And then this is our take home points. When you call the ethics committee, it's not punitive. It's not like, ooh, you're in trouble. You got the ethics committee called on you. And a lot of people think that, but it's more supportive. It's meant to assist patients, family, and staff in making decisions that best align with the stakeholder values, patient's goals, those sorts of things. Don't ever feel afraid to call an ethics consult. But when you're taking your step exam, when it says call an ethics consult, you're not supposed to answer yes because you're supposed to figure it out on your own. But in real life, you don't have to do that. I swear that question just makes me so mad. An ethics consult can be either you can just call and say, can I just get a quick clarification on this? Like, this is what's happening. I'm not really sure which way to go with this. And that can be the end of it. Or we can come in and do a complete formal consult, bring everybody to the table, do a huge care conference with everybody, staff, family, surgeon, everyone. Find out who your ethics committee is and don't be shy to call them. They're there for you. Consider even using an ethics committee just to do education. They're there for education. And then also we would do this at Children's Hospital. If there was a really tough case and there was a lot of people that were just so burned out over this case because it was so hard, nurses, physicians, all of the staff on that unit, we would come in afterwards and debrief cases and talk about it. So that's something else you can use this for. Okay, so that's just a lot. I just gave you a lot. But any questions, thoughts? I know it's late. But is this something you might be interested in?
So every hospital has an ethics.
Every hospital has to have an ethics committee or some way of addressing ethical issues. Sometimes it's one person who's on call all the time. Other small hospitals may just have one physician that's the ethicist. Others have like a whole team of people. Big hospitals like MedStar in Washington, DC, they have a whole team of ethics consultants and everything in between.
I say
You can't have the valve transplant. Then the patient would probably just go back out to the street and he would eventually come back in to the emergency room in distress, or he might cardiac arrest and die. Yeah. Doesn't that just make you feel sick? Like it causes so much distress to make that, like, how do you make that decision to either treat someone that you know is just going to waste that whole surgery and go back out and use drugs, or they're going to go out and die anyway? Like what kind of choice is that? It's no matter what you do, you're going to be distressed. And so ethics can also help think through that distress, like, yes, some of these things are just hard and there's no good answers. Yeah, you were going to say something. Law. Oh, yes. So, okay, the question was, when we're writing policies, how are the ethics policies, do they include law, or how do you, like, how is that done? And our ethics policies usually are part law and part ethics and process. So it'll say, like, for instance, if you, a lot of the ethics stuff that we do, though, isn't written in the policy. Some of it is just, we do it. That's just what we do. A lot of it's communication. A lot of it's just meeting. There's processes that we do that aren't necessarily written. But let's say, for instance, like, do not resuscitate. There's laws that talk about when somebody can refuse a DNR order, or what if the patient can't make their decisions anymore? Can the physicians put a DNR order on them so that if they think they're so sick that they're going to die anyway and resuscitation wouldn't help, can physicians just make the patient DNR without anybody else, let's say they don't have any surrogate family members or friends or anybody that can make those decisions. So there are laws that address those sorts of things. And so those laws will be in the policies, but then we'll also talk about, what does the ethics committee do? Like, call the ethics committee if you need to talk about these things. And so they're kind of all mixed together in there. Medical aid and dying. Some hospitals have policies on medical aid and dying. Obviously, it's going to have some legal, it's going to have some ethics process in there too. A lot of hospitals have organ donation and sort of organ donation and also recipient policies. How do you decide who can get the organ, and those sorts of things. A lot of that's national level, at least the organ registry kind of things, national level, but hospitals still make decisions like, how long does someone have to be clean from drinking before they can get a liver transplant? And again, like, that would be within a policy, and it's not necessarily law, but there's organ donation laws that also cover some of that. So they're mixed. It's all mixed in. What are you going to say? Yeah, every committee is different. Some will actually do a group, like they'll have several people go in together and do the consult. Others will just be one person. And then they'll bring it back to the committee for review, like the whole committee for review. And so there's like many different ways that those are done. I personally like having two people because catch things that the other person doesn't, and you can sort of hear things that the other person doesn't hear. I personally like doing that best, but not every hospital has the resources to do that. So I know we got to get going. So I am happy to answer any other questions that y'all have about this. You can also contact me. I'm at Michigan State University. I'm on the website for the Center for Bioethics and Social Justice. It's Jen McCurdy. You can contact me anytime you have an ethics question or issue or anything that comes up in your clinicals or anything. I'm happy to talk to you. But thank you so much for being here, and I wish you luck.